Good morning everybody and welcome to my presentation today. For those of you that don't know me, my name is Nikki Knightley and I am the bone marrow transplant ACP, and for the purpose of this talk I'm going to talk to you about the transplant pre and post care of our autograft patients. This slide just gives you an overview really of the autograft journey in its wholesome. As you can see, there are various steps which patients need to go through as part of their pathway, but for the purpose of this talk we're really just going to focus on kind of what happens pre-transplant and what happens post-transplant. So if we just focus on the actual transplant part of the patient's whole treatment pathway, there is kind of broken down really, I suppose, into these three steps. So patients have chemotherapy, they get a response from the treatment, they then move on to harvesting and collecting stem cells, followed by their admission to Dove unit for the actual transplant itself. But there are lots of things that happen really before a patient can even get to that point. So what generally happens is we receive referrals from the patient's consultant into the transplant service. They'll then be allocated one of our transplant consultants, and that's currently Dr. Griffith as the transplant lead and Dr. Sternberg. They will then have a telephone consultation with me where I will give them kind of an overview of what the transplant is, and I will send them some written information generally in the post. And often at that point patients have done their own little bit of research, so they've got a little bit of an understanding, or they've spoken to some of you on the day units to get an idea of what transplant is. Once that's kind of happened, we then have a very long conversation at their initial appointment with us in clinic about the transplant, and we really break it down into three stages. There is the kind of harvesting and the workup stage, there's then the admission stage, and then there is the discharge stage. And it's really important that we evaluate patients' fitness right from the offset. So even at that very first appointment, when we're just giving them an overview of what transplant is and what that looks like, we'll be doing a kind of mental assessment of their physical ability, of their mental ability, and just generally kind of engaging what their thoughts are on the whole process. And once patients have agreed that they feel that this would be the right pathway for them to go down, and we also, you know, on our initial assessments agree, there are really three things that need to happen to ensure that patients will be suitable for getting to the transplant stage. So the first thing is they need to be physically fit and they need to have a good performance status. And by this, I don't mean they need to be running marathons or they need to be, you know, working. They just need to be able to be have a performance status really of 0 or 1. So they're either able to carry out all their usual activities, or they're able to carry out most of their activities, maybe spending 50% of the day sat down. And for some patients, when they come to clinic, they'll that first initial appointment, they'll come in a wheelchair, or you know they'll be quite frail, and so it's really important right from the offset, if we're concerned about that we're honest with patients about that, and then we also maybe try and put in some early intervention to support them with becoming a bit more robust. And that's, you know, we talk about physical, but we also think about the mental as well. So if we've got a patient who we feel is mentally struggling, even right from the offset, then we will consider an early referral to psychology. So the second thing we need to be sure of is that patients have responded well to treatment. There is no point taking a patient to transplant if you do not have control of their disease, and therefore their disease will be reassessed depending on what their actual diagnosis is. If they're a myeloma patient, they'll be being monitored with blood tests, so maybe their paraproteins or their serum free light chains are being monitored. And we will also do a bone marrow before collecting stem cells. If they're a lymphoma patient, then it is probably they will have had a PET scan or a CT scan prior to us taking them to harvest. If patients haven't responded, That doesn't mean they're ineligible of transplant, it just means we need to have a discussion with the MDT about looking at alternative treatments. And for example, if it was a myeloma patient who were having standard DVTD chemotherapy, it may be we switch them to something like DT-PACE, which is a much stronger regime and will hopefully get the disease under control to allow us to then take that patient to transplant. The third thing that needs to happen is, even if you've achieved point 1 and 2, you need to have a sufficient number of stem cells. And for the majority of patients, we do harvest sufficient numbers of stem cells, and this generally needs to be more than 2.5 million. However, there are the occasion when, despite all the other things being where we want them to do, patients go to Oxford and are unable to get stem cells. And without the stem cells, we're unable to do the transplant. And in those circumstances, again, it would depend on the disease and it would depend on the patient's risk factors as to what our next steps would be. For some patients, maybe myeloma patients, that may be then that we just watch and wait their disease. For other patients, potentially a lymphoma, or maybe a myeloma who's got high-risk disease in a young patient, we would then maybe have to have discussions about whether we take them to an allograft transplant. So this diagram to the right of the screen, this highlights all of the kind of evaluation of fitness tests that we need to do, or assessments that we need to do ahead of bringing a patient in for transplant. And that relates to the SOP, and you can see the number in brackets there. So if you wanted to look in more detail, by all means, head over to the JCT drive and review that document further. But you can see there are a number of factors that we need to consider to assess a patient's evaluation of fitness before we can take them to transplant. So there are various things that we need to do alongside that initial assessment, and some of these are done pre-stem cell harvesting and some of them are done post, and that often depends on the patient's individual needs. But in essence, patients will have a minimum of 6 referrals made. So those in the mandatory section, they are baseline investigations at the top there. So you've got an echocardiogram, an ECG and lung function test. That is done for all patients, and that is done to ensure that their vital organs really would substand the significant high-dose chemotherapy we're going to give these patients. All patients as standard will be given and asked to take part in a psychological assessment and appointment. And as I alluded to earlier, if we've got a patient who we feel is struggling psychologically or may require more than 1 or 2 appointments with the psychologist, we will do an early referral. We've got a really good relationship with the psychology team, and these patients are seen pre-admission. They are also offered additional support while they're in if required, and then they also have further follow-up after they've been discharged. All patients have to have some form of dental assessment, and this may be with their local dentist, in which we will provide them with a letter to get signed from their dentist, or if patients don't have a dentist, which is more of a common theme these days, then we will refer them to the hospital dentist. And again, we've developed a really good working relationship with them, and they will see patients and undertake any necessary dental work. Now, the reason we do the dental assessment is because if patients have got any broken teeth, any cavities or any heavy decay, this could become infected during the transplant and cause detrimental effects. So it's really important that we try and eliminate any risk of infection before we undergo the treatment. All patients are now referred for a PICC line. If they have poor venous access, it may be that they've had an apheresis line inserted prior to stem cell harvesting. And for those of you that have been around for a number of years, you will be aware that we used to use Hickman lines as standard. I'm really pleased that we've moved away from that in the kind of last 12 months or so. It really does improve patient experience. They don't need to go to theatre, and the lines can be easily removed on the day unit, which means we are getting them out much quicker. And then all patients will undergo respiratory swabs prior to admission, and that is again to ensure they're not bringing any respiratory viruses. So that's an extended panel which covers all the flus and things like rhinovirus as well. They will also have a number of blood tests, so they will have virology screening blood tests, and they will also have a lot of routine bloods, and then again that's just to make sure that the bloods and things are stable, and there are no surprises on those before we initiate them for transplant. In addition to that, patients will also be referred to other services if required. So we will refer some of the ladies to our hairdresser for a wig referral. That's also open to men, although this is the uptake for this is nowhere near as popular as for females. And you may wonder why this is being done at transplant and not prior to this. Well, often with patients, particularly the myeloma patients having DVTD chemotherapy, they've not suffered hair loss at all, and so it's when they come to us for the transplant consultation, we talk to them about cyclophosphamide, for instance, which does cause hair loss, that's the time we're really doing those referrals. And again, psychologically, that's another new factor patients have to kind of consider, process and digest, the fact that they're going to lose their hair. We will often refer patients over to citizens advice, and that could be for financial and benefit support, or it could also be for things like a blue badge. And I encourage patients to apply for a blue badge because often their mobility is reduced after transplant, maybe due to even just general fatigue, and because they'll be attending numerous hospital appointments, it just takes the pressure off trying to park in the hospital car parks and struggle into the hospital. All patients will see the dietitian while they're an inpatient, but it may be that patients have lost a significant amount of weight at point of diagnosis or during their initial treatment, and so we may do an early referral to the dietitian. And the same with the physiotherapist. If patients are struggling or they've become less mobile, we will do an early referral to the personalised care team physio to try and get some prehab done for these patients. So for a transplant patient, coming into the ward and during all that workup period, they could have anywhere between 7 or 10 or 11 referrals per patient. So it's quite a significant amount of work that's done in the background in order that these patients are fit for transplant. So I'm going to move on now and talk a little bit about the pre-transplant talk and consent. So once we've done all those workup investigations and we've identified admission dates for transplant, we will aim to see the patient the week before they're due to be admitted to provide them with all the necessary information and do the consent. So the pre-transplant talk, again, is defined by our SOP, and you can see that in the middle if you wanted to refer back to that. But these are all the things that are discussed as part of a pre-transplant talk. And the real aim of this is to provide patients with an overview of what their transplant admission pathway will look like, but also to make sure they're fully informed about all the possible side effects, to provide them with practical advice, but to also make sure that they are fully informed about what they are about to undertake. And I think that's really important. And I try and do this talk before they actually see the consultant for consent. It usually takes an hour on average, but depending on the patient's needs and depending on their psychological state going into this process, this may take anywhere between 1 and 2 hours. And even at this point, they may have undergone all of those workup tests and everything from a kind of physical point of view is looking really good for transplant. It may be even we get to this appointment and we identify that these patients have got new symptoms, kind of clinical symptoms, or psychologically they are not in the mental headspace to proceed to transplant. And even at this point, the week before, we have on occasions deferred patients' transplant because we feel they need some additional support, either to support them psychologically or to get new symptoms under control, whether that be the progression of disease or they've developed things like coughs or colds or infections, and we feel the safest thing to do would be to delay their transplant. So as you can see from around that kind of circle there are various things that we discuss, and these conversations can be quite hard-hitting for patients. We tell them all of the side effects, and we tell them worst case scenario. We do highlight that it's possible they won't get all of those or to that severity, but it's a very frank conversation and a very realistic conversation. We also talk to them about the risk of going to intensive care, and also about the risk of death and dying through this process. And sometimes it's almost like that's the first time they've realised or heard that that is a possibility. And we generally quote a kind of between 2 and 5% chance of dying through this process. That again is quite individual for the patient. And certainly in my experience in the last 7 years of doing autografts, we've only had 1 death. And I do highlight that to patients, but equally it's about ensuring they've had the time and space to think about that, but also to get any affairs in order ahead of their admission. We also talk to them again about psychological support, and that's not just for the patient, but also for the relative, and we do offer that to them if they require it. We then, if there are any last minute referrals we need to think about, or just informing all the necessary MDT members of this patient's admission, that will be done. And as I said, really just talking about practicality, so things to bring into hospital, and kind of showing them photographs of what the process of stem cell reinfusion looks like, but also photographs of the rooms. So following that, patients will then meet with the transplant consultant and myself for the consent process. And it's really important that this is an informed consent. And what I mean by that is that we fully inform them, as I've said, about the nature of the treatment and the risks involved with that. We also talk to them about the benefits of the transplant, but also any alternatives. So if they didn't have a transplant, what would be the other options? And it's really important that you do that, because then that allows the patients to make a balanced, informed decision about what they are undertaking. And this process happens not just at that appointment prior to admission, it's happening the whole way through. And patients are fully aware that this is a treatment option. It's not the definitive that has to happen. We also make sure we give them time and space on various appointments, and they know they can ring me at any point to kind of discuss any questions they have. And this really is joint working between the transplant consultant, myself, the patient, but also making sure we get the kind of input of all the support services. So you guys, as the nurses on the day unit, if you're concerned about patients, it's really important you escalate that to us. The psychologist, the dietitian, the physio, and anyone else really who's involved in the patient. So it's quite an in-depth process that happens leading up to transplant, and certainly this appointment, as I say, patients come for a pre-transplant talk, which generally takes an hour to 2 hours, but then we'll also spend between half an hour and an hour with the consultant. So it's a good 3 hours just on this consent process alone. So once we've done all of that, the patients are then generally admitted, and as you know, I will see them regularly on the ward, and all of the kind of inpatient care, you know, is discussed in separate presentations, or is information you're aware of, or certainly information we'll discuss this afternoon in the face-to-face sessions. So I'm going to jump now, and I'm going to talk to you about the patients going home. And I think this is always a time of mixed emotions. Certainly, I would say there is a lot of relief for patients when they get to the point of going home. There is, you know, sometimes feelings of elation, and they're happy. They almost disbelieve it sometimes that they've got through it and they've done it. But there's also a whole load of other mixed emotions around anxiety and concern and worry. And certainly from a relative's perspective, all of those emotions are also there. excuse me. So, you know, it's really important that we get the discharge of these patients right, because it has a massive impact on the patient's recovery, but also how the relative feels. And they become, you know, the kind of carer or the point of contact for their loved one. And that can be quite scary for them. So in order for patients to be discharged from the ward, there are lots of things that need to happen. And often we focus on stem cells being above 1, but I think that's really a kind of minute part of it. There are lots of other things that need to happen. This diagram shows kind of all of those things that encompass what a discharge needs to look like. So yes, count recovery in the red is really important. We need to know that a patient's had a neutrophil count of above 1 for 3 consecutive days. But it's not just about the neutrophil count. It's about whether their hemoglobin is sufficient. It's about whether their platelets are stable. If patients are still requiring daily blood transfusions or daily platelet transfusions, then it's unlikely we're going to be able to get them home. And it may be we just need to hang on to them for a little bit longer. They also need to be clinically well. So yes, their counts may have recovered. They may not be needing blood transfusion or platelet transfusions, but they may still be spiking temperatures, or they may still be suffering with nausea and vomiting, or they may not be eating. All of these things are just as important as what the numbers tell us, and often more so. So it's really important we're kind of doing a full holistic need assessment of our patients. They need to be mobilising, and you know, some of you will be fully aware that I will take patients out of the ward, and I think this is really important because it's a huge shock for patients from being cooped up in a room for a few weeks to then being discharged and thinking they can walk the length of the corridor and down the lift and out into the car. So it's really beneficial for them just to start going off the ward for short walks or even in a wheelchair. They shouldn't be doing that on their own. They should be doing that with a relative. And I know now there are many more patients who do not stay confined to their rooms for the whole of their admission. And I think there was a lot of nervousness around that initially, but I think it certainly benefits the patients to be able to go off the ward even during their kind of inpatient stay, as long as they're doing that safely. So I always say to patients, once they've had their chemo and their stem cells, they should not be leaving the ward on their own. They should be going with a relative or a member of staff. They need to be wearing a mask, and we need to really be taking a wheelchair with them if there has been a bit wobbly. And they mustn't be attached to any drips or treatments. The garden is progressing, and I think this will have such a huge benefit to patients to be able to go out to a safe space. It will mean they don't have to go in the lift. It will mean they're not walking long distances to, you know, go down in the lift to get outside. So I think that's going to have a huge impact on the recovery of our patients. But in the meantime, we just need to carry on doing what we've been doing. And then in the orange there, patients need support. So it's making sure if a patient's being discharged, all their family members have not gone off on holiday, and that even if they're going home on their own, that they've got good support around them. And once we've done all of that, then we can really consider a safe discharge for these group of patients. And I think it's all of our responsibility to make sure all of these things are happening. So yeah, just kind of really be mindful when you hear myself or the doctor saying, yeah, we're going to think about discharge towards the end of the week. Have all of these other things been covered off? So on the day of discharge, there are a number of things that need to happen. And again, this is really a joint effort from all of us. And I think discharge, getting it right is the crucial thing we can do for transplant patients, for all the patients, but specifically for transplant patients, there are a number of things that need to happen. From my point of view, I will do a couple of things with patients. I will ensure they have had the necessary discharge talk, so they'll be given written information on coping with discharge, which is on the T drive, and if you wanted to have a look at that, by all means, please feel free. That contains all relevant contact numbers, but it also gives them advice about managing symptoms, what will happen after discharge, and kind of longer term support and advice. I'll make sure they've got the triage card and they've got a pants card, and I will really just give them that time and space to talk about how they're feeling about going home. But I will also ask them for feedback about their experience on the ward. And all patients are sent a questionnaire, but that usually goes out about 6 to 12 months after. So in the short term, I will ask them, how have you found your inpatient stay? Is there anything we're doing that we could do to improve? And often patients will say, no, it's been brilliant. Everything you've told me, I've expected. It's not been as bad as I thought it was going to be. But there are occasions when patients will say to me, actually, Nikki, there's been a couple of things that I think could be better. And I just want to give you a couple of ideas of insight for that. Sometimes it's about the cleaning. And I always encourage patients to raise things as they happen, but sometimes patients feel they're not able to. So it may be that they say, actually, the cleaners, my bathroom hasn't been cleaned properly and I've had to do it myself. Or it may be things around things that have happened on the ward. So they're little things that I think we don't necessarily realise as nursing staff. And the two things that have come up over the last kind of couple of months is around noise. And patients have said to me, it's really noisy. And I don't think the nurses realise how loud they speak, particularly at night. And the other one I've heard is that the trolleys outside the rooms, so where all the blood bottles and bits and pieces are kept, I think when they're topped up or they're being counted or cleaned, people throwing blood bottles back into those plastic trays actually echoes through the room. So I suppose really at this point it's just really my plea just to maybe think a little bit, and I know we're already busy and these things, we don't even think about these things, but it's just about being mindful. If you're sat outside a patient's room filling up a trolley or having a chat or a conversation, patients can hear everything in those rooms, so just be a little bit mindful about that. But I always welcome patient feedback, and I always say to them, this is not a criticism of us as a service, this is ways that we can improve, and I really value patients' feedback about that. So then the doctors, their responsibilities really are to make sure the TTAs are prescribed. Within the patient's transplant folder, there is a timetable which very clearly identifies for our doctors what needs to be prescribed. And I think really it's our job as nurses just to ensure everything is prescribed. We have kind of quite an overturn of junior doctors on the ward. The GP trainees are only with us for about 3 months. And I think this can their experience in transplant is not as expanded as ours, so it's important we work with them, but also to make sure they've got day therapy unit reviews booked, and this generally should be twice a week initially, including pick bloods. So yeah, it's just to make sure that that's done before the patient goes home, and ideally that the patient's had a copy of that letter. And then from a ward nurse's point of view, it's really important that we explain those TTAs. So patients need to know what they need to take when they go home. And ideally, if that can be done when a relative is present, that just takes the pressure off the patient having to remember. Again, just highlighting, making sure they've got the triage card and that their pants card is up to date, and making sure they've got a blood form for their next appointment. Now, patients who are going home after transplant will be coming back to day therapy twice a week for the reviews, and it's really important they do that because we need to keep an eye on them. They will go home with a PICC line most of the time, so it's important that they're having their PICC bloods done on the day unit. And the reason for that is we need to be seeing those patients and assessing them. A couple of patients recently have been referred to SWIC, and whilst that would be the normal process for patients being discharged, we want to minimise the number of places patients are going to. And also, if patients go to SWIC, we do not get the blood results the same day. So it's really important that patients are booked to day therapy for the bloods. So please, can I ask that you don't refer transplant patients to SWIC on discharge? If they need to be referred at a later date, then that can be done. But in general terms, their PICC line will come out usually between 2 to 4 weeks after discharge. And by that point, their reviews have reduced significantly. So arrangements for follow-up. Patients are discharged from the ward, and from a ward perspective, that's kind of their episode of care completed. But for us as a transplant service, it ramps up a little bit again, I suppose. So, you know, we've talked about follow-up, and initially patients will be followed up twice a week. Once their counts are stable, then this will reduce potentially to once a week, once a fortnight. And they will generally then go back to be seen in the transplant outpatient consultant clinic, usually around 4 weeks after discharge. It's really important patients, as I've said, are given triage information and are aware of readmission advice. In general terms, most patients don't get readmitted to hospital. There may be a couple, but generally over the year that doesn't happen. But there are lots of important things we need to do. So we need to make sure patients are on acyclovir for 90 days as a minimum, and they will also have cotrimoxazole for 120 days. And the guidelines for starting cotrimoxazole is a patient must have a platelet count of over 30 and a neutrophil count of 1.5 or more. So they may go home with cotrimoxazole, but really they shouldn't be starting that until their parameters of their bloods has improved. And this can all be found in the arrangements for follow-up SOP on the T drive. Patients should continue to have irradiated blood products, and this should continue for at least 3 months post-transplant. And then patients will then go into kind of the longer term follow-up. And that will include a 100-day assessment, followed by referral back to their own consultant. They may then be passed over to the long-term nurse follow-up clinic. They may be offered annual holistic needs assessments, and they will undergo their vaccination schedule. So patients, once their blood counts will have recovered, they will have their Hickman line or their PICC line removed, and that's generally when their platelet count is above 50 and they've got a stable neutrophil count. They will then have their disease reassessment, and again that happens at around 100 days, and depending on their disease will depend on what that assessment looks like. So for a lymphoma patient, they may have a PET scan, and for a myeloma patient that would be a repeat bone marrow biopsy, and that really is just to assess how well they've responded to the transplant treatment. Once they have had those assessments, we will then do a discharge summary back to the patient's referring consultant, and they will be picked back up in the routine haematology, myeloma or lymphoma clinic. And the landscape of what happens next is changing. So previously for a myeloma patient, once they'd had their initial chemo, then their transplant, then they would just be monitored. But as treatment improves, they now generally have 4 cycles of chemotherapy, their transplant, and then 2 further cycles of chemo, followed by maintenance chemotherapy, depending on what regime they're having. So treatment doesn't necessarily stop after transplant. Patients will go on to have regular blood monitoring, and as alluded to earlier, they will have ongoing acyclovir cotrimoxazole as a minimum, with potentially other treatment if that's seen as the right thing to do for that patient, and that's usually decided at an MDT meeting. Patients will require vaccinations, so they will require an annual flu vaccination. They will also require all of their childhood vaccinations, which usually is a schedule that starts about 6 months after transplant and goes on to at least 2 years. Patients are advised to avoid any live vaccines for at least 2 years post-transplant, and the reason for that is the vaccine strain could replicate too much and cause kind of an extensive or serious infection. So this includes things like the MMR vaccine and the live shingles vaccine. In relation to COVID-19, patients are encouraged to be revaccinated, and this generally starts 90 days post-transplant. They will be offered a full revaccination programme, including all boosters. They can still get lateral flow tests from the government, and And there is full advice about COVID vaccinations on the Anthony Nolan website, and if they do become positive for COVID, then they may still be eligible for the antiviral therapy. And we encourage patients to wear masks in crowded places still. Obviously, COVID guidelines are forever changing, and the up-to-date guidance is always available on the Anthony Nolan website. So I'm just going to briefly talk about kind of longer term follow-up. So we know the transplant landscape is evolving, and we know that patients are living longer. And so this graph really is just taken from statistics from EBMT, which runs from 1990 to 2019. And as you can see on there, the number of transplants for both autograft and allograft is significantly increased. And will have increased even more since 2019. So it's really important that as the kind of longer term survival probability increases, that we manage and recognise late effects of transplants. And there's been a real kind of focus, particularly in the last couple of years, about long-term follow-up of these patients and how that's managed. So I run a long-term follow-up clinic, and that is currently open to lymphoma patients, and allograft patients are slowly moving into that clinic. But really, what the focus of that clinic is, and what we should be doing for all patients, is just providing them with recommendations about managing their own health, but also looking for kind of early detection of any longer term effects. So these are the types of things that we recommend to patients. They should have annual optician review, annual dental reviews. They should be wearing factor 30 at a minimum sun cream. They should participate in any screening programs that they're sent, so things like the bowel screening, mammograms, smear screening, and there's also a new lung health checks, and I'm sure there'll be more screening programs that come, but also just being self-aware and checking for any signs and symptoms, and seeking support and advice on those at the earliest opportunity. We also encourage patients to have a healthy lifestyle, so it's about eating well, and trying to kind of have a well-balanced diet. We encourage them to give up things like smoking, and can offer support with that, but also to just trying to keep active. And that could be in various ways. It doesn't have to be vigorous gym classes. It could be swimming. It could be just even going for walks. And there is lots of support available now through the personalised care team to help with these things too. So just to summarise, we always tell patients the transplant pathway is a marathon, it's not a sprint. This is a long process of care, and can take a good 12 months from start to finish, really, from kind of referral right up to recovery. And for some patients they may even have longer effects than that. It's a real roller coaster, both mentally and physically. Patients can be on one treatment pathway and then that gets switched because they've not responded, but also mentally they can go through emotions of feeling very strong to feeling completely drained, to feeling very tearful, to very happy, elated, anxious. All of these emotions, it really is a real roller coaster for them. And it's draining. It can be physically draining, it can be mentally draining, and that can all lead to a lack of motivation. So it's really important we try and prepare patients as much as possible for every step of this pathway, whether that be for harvesting to admission and certainly to discharge. But things that I do tell patients they can do: seafood as medicine. When they're inpatients particularly, they've got no appetite, nothing tastes very nice. But seafood as medicine. It doesn't taste very nice, I don't want it, but I know it's going to help me get better. And I try and use that analogy to patients, pre-admission, during admission, and certainly after they've been discharged home. And most importantly, to be kind to themselves. This is a real journey for these patients to go on, and sometimes they can be a bit hard on themselves, but it's about being kind and taking the time when they need to. So I think for all of us, it's really important that we really embrace that multidisciplinary approach to the transplant pathway, and to just be really mindful about what our role is within this journey, and particularly for those patients going home from the ward, ensuring they've got everything they need for a safe and good discharge. So thank you for listening. I hope that's been useful. As always, if you've got any questions about anything I've said, then please don't hesitate to contact me, or if there's anything you think we could be doing differently, I'm always open to discussions around that too. I hope you enjoy the rest of the day. Thank you very much.